A 50-year-old male presents with ankle pain. Is the x-ray worrying? Let's go through the case. Here we have an x-ray of the ankle, and we can see there is a lesion within the distal tibia. Have another look at the lateral view. Approaching bone lesions on x-ray can be challenging as there are lots of different causes, but a key concept is to decide whether the lesion has aggressive or non-aggressive features. To help us with the differential, let's look at 6 different factors. Firstly, decide if we're dealing with someone whose growth plates are fused, as this can change the differential. Here, this is an adult. Think about the location. Is it within the metaphysis, diaphysis, or epiphysis? Is it central or more peripheral towards the cortex? Our lesion is predominantly within diaphysis and mainly peripheral. Is there bone destruction, and what is the pattern? Complete destruction of the cortex like we have here usually means an aggressive lesion. What is a zone of transition? Is it wide or narrow? A narrow zone of transition means you can draw around the lesion with a pencil. Our lesion has a wide zone of transition at its superior and inferior borders. Is there a periosteal reaction, and what is the pattern? Thick periosteal reaction can be a marker of a benign lesion. However, there are more aggressive patterns. Look at the lateral view and the slither of bone elevated from the rest of the cortex. This is called a Codman triangle and is an aggressive pattern of periosteal reaction. Lastly, look for a soft tissue mass, again which would signify an aggressive lesion. If we look closely at the lateral view, there may be the outline of a lesion here adjacent to the cortical destruction. The destruction, wide zone of transition and Codman triangle all point to an aggressive lesion. The first differential of which for an adult patient would be a bone metastasis. A lytic lesion related to multiple myeloma is also possible. A benign but aggressive process such as osteomyelitis is also within the differential. And lastly, a primary bone tumour. The age doesn't fit an osteosarcoma, which usually affects younger patients. We should consider a chondrosarcoma, however we may expect to see ring and arc-like calcification, which we don't have here. With a bone metastasis, the number 1 differential, we should think about what tumours spread to bone. We can divide this into those that give predominantly lytic lesions such as lung, renal and thyroid, those that give predominantly sclerotic metastases such as prostate, and those that give a mix, and here we have breast. On this CT scan we can see a large tumour related to the right kidney. This was renal cell carcinoma with associated metastatic bone disease. So remember to use the 6 factors to assess any bone lesion on x-ray to help you decide if you're dealing with an aggressive lesion.